Okay, terrific. All right, well, welcome everybody. For those of you who don't know, I'm Dr. Eric Kaler. You're at the Healing Your Foot and Ankle Pain Naturally Without Medications, Drugs, or Surgery. And today's format's pretty simple. Before we get into it, a couple of things. For those of you that haven't been here before, we've got 2 restrooms. If you need to stand up and move and get to the restroom, go ahead and do so. Through 2 doors and to the right is 1 restroom, and then through this door and the second right is another. Everybody got water or refreshment? Okay, all right. Great. So what we do here is pretty straightforward. I'm going to tell you a little bit about who I am and who the clinic is. Some people advise me it's not a great start because I do want to find out about you, but it helps so that you understand the perspective of myself as the owner and founder of the clinic and what we do here. And then I want to find out what brought you here to the clinic for this presentation so that I'm sure to include it or some information that's valuable to you. And then I provide some information about basic function of the ankle and foot. We'll go over things that can go wrong with the ankle and foot that most individuals who show up at these might have 1 or more of those things. And then we'll have an opportunity to see what's called a 5-minute miracle. You get a chance to see what an assessment intervention looks like in real time. And then we'll give some ideas of what the next best steps for those of you that are seeing value in this and want to move forward. Sound fair?
You bet.
Perfect. All right. If you could do me a huge favor, Lisa.
Of course.
Grab that ankle and foot model out of the hallway. Should be in the cabinet just above the sink, right in the sink. So we help people achieve greater mobility and strength for their active life without medications, drugs, or surgery, even when nothing else has worked. That has been the mission of the clinic since it started, and I'll tell you a little bit about why it started. I've got some slideshows for you, but I'll tell you straight up. So I was a physical therapist of over 25 years, and I went through a high-level professional training program called the Fellowship Training Program. And from that, I learned real in-depth both the research in the literature and what can be done at a high level in a clinic to help people overcome pain conditions and movement problems from head to toe. My head wanted to explode because the difference between what's offered to people in the community, my friends and neighbor and families, and what's possible was great. And I just felt compelled to offer something where I'm an independent practice, where I don't have to answer to any administration looking at quotas for things such as surgery and imagery and that sort of thing. I don't have anything against surgery and imagery and injections. They're just over-applied. And oftentimes they're over-applied in the absence of other good options that have been discussed with the patient. We believe that we want to have an educated person in front of us who can make a choice. You can only make a good choice when you have options, when you have all the reasonable options. And that's clearly not being offered when we go to providers right now. And that's why the clinic was started almost 6 years ago. So it's a little bit about the clinic, right? So I've had over 30 years of clinical experience, talked a little bit about fellowship training. Dr. Jessica is a clinician of 1 year she's been here now. She's in a fellowship training right now, and she's another doctor of physical therapy here. We've got another provider, Dr. Rebecca. She's trained in the fellowship program for applied movement science. She was voted the Physical Therapist of the Year in 2017, and patients know why. They love her. Gina's a physical therapist assistant. She's been with us for a year and a half. She's specially trained in pain relief and sports recovery massage. She's a certified spine specialist. She's a certified upper extremity specialist. Courtney's a physical therapist assistant with over 6 years of experience. Most of that independently in home health. She's specially trained in pain relief and sports recovery massage, certified spine specialist, certified upper and lower body specialist. Obviously, you get the idea that we value clinical education, not to pat ourselves on the back, but to provide the best customer experience. Lori Shades is an occupational therapist. She was the first person I called when I decided to open up a clinic to come on board. She's specially trained in edema and lymphedema, and she gets a chance to mentor and teach that worldwide, or the nationwide. So we want to make people have better. We want people to have We want to enable people to make better healthcare decisions through education. Education both about yes or no, we want to come forward and get some care here, and we want to help people understand what the value is of non-surgical or non-drug intervention is. So if someone's unsure or stuck or not sure what to do, we want to be a resource for them. And we certainly don't want, we won't ever disrespect anybody and say, what do you expect at your age, or you just have to live with it. Like, you will not hear that here. There's some significance sometimes to the age of a person, but people of any age and any current ability can improve. So that's a little bit about who we are and what we do here. So a big mistake that people do with ankle and foot problems is they do nothing. Obviously over time that just compounds issues, right? Although we can't pay attention to every little ache and pain that's whimsical, when it sticks around for a while, something's there. Like some of you mentioned that, yeah, I know something's going on, and you know enough that I need to do something. So you're getting some education, that's good. The longer you have a problem, obviously the longer it can take to correct it, but no problem is around so long that you can't make significant improvement of it. I'm always pleasantly, I don't know, amazed I think would be the term, at how much people can improve, even when they've been with something, but obviously the sooner you to a problem that you're having, that you get a resource, the more quick you can get a resolution. Masking pain with non-steroidal anti-inflammatories, braces, gels, creams, potions, and lotions, and medications oftentimes doesn't necessarily get to the root of the problem. We know there's side effects of many of those, including the NSAIDs even. The over-the-counter or prescription non-steroidal anti-inflammatories, what are the side effects of those, anyone? Ibuprofen. So certainly it can have, can cause
your stomach must be.
Stomach problems,
Yeah.
stress of the kidneys, stress of the liver.
Right.
Cardiac stress, they're starting to find, and actually some evolving research is showing that it can even accelerate the process of arthritis, the very same thing that people oftentimes take it for. Be that as it may, there's potential side effects of those. Folks that are masking it aren't getting closer to a solution, in part because they're ignoring comprehensive treatment. We'll talk about what comprehensive treatment looks like from our perspective. You were kind of alluded to that it's kind of like, oh, put this on, put that on, do this, kind of like just a kind of a poke in the dark. And maybe see how that works. We'll talk about what comprehensive looks like. Relying on a single solution for your problem rarely gets to the source, especially if you're only relying on surgery or injections. So we all want to feel that we're constantly moving forward and getting pain relief and getting stronger in the daily things that we want to be able to do. Everybody's why is a little bit different, right? Some people, they don't want to lose their independence. They want to be able to keep up with friends and family. They want to be able to respond to that call. Hey, would you like to go out and do this? Instead of thinking, oh, I don't know if I can do that. What do I pack? How long are you going to be gone? A nice spot that would be at. Everybody, like I said, everybody's activity is a little bit different. So, I'm going to talk a little bit about the basic anatomy of the ankle and foot, and we'll cover that a little bit in the diagram. I'll pass this around a little bit too. This is a model of a right foot, and it's just plastic. It's not the real bones, if you will. But you can think of a couple of basic regions. There's the ankle region, midfoot region, and the forefoot region. The ankle region is comprised actually of three bones. Your inside larger bone called your tibia, your outside smaller bone called your fibula. There's actually people that can break their fibula and it may not even be painful, or they may not even know it. These two bones do have a little bit of movement. There's a little bit of movement that glides up and down to allow for, in a sense, expansion of that joint. When the bone they're sitting on top of, the talus, when that moves underneath it, there needs to be a little more room in that area. So you'll see how the talus here, which is the next part of the base ankle bone, is a little bit wider in the front than it is in the back. You can play with all of these as well. So this ankle joint hinges, a fair amount of movement occurs there. There's also a fair amount of movement that occurs in the rear foot, in the bone called the calcaneus, the heel bone. The calf muscle comes down and inserts to this bony area in the top. And the bottom, where this bony bump is here, is where the connective tissue to the front of the foot goes. So when people get plantar fasciitis or foot pain, oftentimes it's tender through that area. This serves as a teeter-totter, right? So certainly significant problems can occur, foot problems in movement or problems in the connective tissue in that region. Small amounts of movement are evident in all these bones, and especially in the great toe and the toes, they can bend backwards. So this is kind of a bony representation of the ankle and foot. Wanted you to pay particular attention to a little more complexity of the ankle and foot. Sometimes people think, well, the ankle is just kind of like a hinge down there somehow, right? But the inner workings of the ankle and foot are much more detailed than that, and we use that to our advantage when we assess it and when we treat it. So I'll let you guys, starting here, you can kind of fiddle with that as I talk about a little bit more. Any particular questions or interests you'd like addressed in terms of the anatomy to start with? We'll get into some later on, so you can ask questions as we go along. But most common causes of ankle and foot pain, classified into different areas: arthritis, tendinitis or tendinosis, we'll talk about the difference, flat-footedness, heel spurs, plantar fascia pain, talk about each of these, neuropathy, we'll cover that a little bit today, ankle and foot joint stiffness, limited mobility in the big toe, nerve-related foot pain, lower back-related foot pain, or called referred pain. So there's obviously a number of things that can go wrong. These are just a sample of very common things that we tend to see and very common things that we assess on a regular basis. First off, arthritis. Arthritis, simply a change in the joint with an inflammatory component. So the structure of the joint looks different, right? It's diagnosed typically as rheumatoid or osteoarthritis. Rheumatoid arthritis was thought historically to be, it's a autoimmune problem. It affects smaller joints. Osteoarthritis is historically considered a wear and tear kind of condition where big joints, such as the knee, such as the ankle, such as the lower back, might experience from a lot of weight bearing. That's the classic description, but there's a lot of overlay. Osteoarthritis has an inflammatory component, which is a major driver, and actually a immune component. And rheumatoid arthritis also has a component of it in which the joint structure actually changes. These individuals are affected more with pain after rest. So that morning pain and stiffness, you get stiff after you've been sitting down for a while, you get up, maybe you move a little bit, it loosens up a little bit, and then maybe it gets a bit worse the more you're on it. People who have this condition can't be as active as they'd like to be. The pain prevents them from that. And, it's not uncommon for individuals who have 50 plus birthday candles on their cake to experience some arthritis, right? I think we all classify that in this room, right? And that's just part of the deal, but it doesn't mean that people can't get appreciably better. Oftentimes a discussion in physician's office, regrettably, is, well, you got ankle arthritis. Take these pills, when it gets bad enough, we'll send you to surgeon, talk about ankle joint replacement. That's literally the type of discussions that people tend to have, right?
Yeah, that's a good count.
Tendinitis, tendinosis, I don't think we need to really get in the weeds here. Tendons are basically what the muscle uses to insert into bones. So if you look up here on the diagram, the calf muscle comes down that white portion, then it connects to the back of that heel bone. That's what the muscle uses to insert into bones. Tendon, very tough tissue. The tensile strength of that is 10 times greater than steel per surface area. It's phenomenal, right? But that area there can become an inflammation. There can just as likely become tendinosis, in which there's irregular tissues that will be. So tendons oftentimes have a real regular pattern of connective tissue that lays down. That can become thin like Swiss cheese under certain circumstances and have abnormal nerve growth into it that causes a pain condition. It's a newer understanding of how tendons are bothersome, and we don't exactly always know why that is, but generally a tendinitis situation is you're going to have inflammation direct irritation on that area and maybe some swelling. A lot of people have pain on their tendons and none of that swelling. So it's oftentimes important to understand that it could be both. Underlying tissues might be abnormal, or there might be an abnormal amount of swelling, or possibly both. Those tendons can feel weak. There may, like I said, there may be swelling. More movement equals more pain. Classically, this type of issue, if you go to the podiatric route, they're going to put you in a walking boot. Limit the movement for a period of time, and then okay, let that calm down for 6 to 8 weeks, and now start to move, right? Anti-inflammatory medications may help to a point. We've already talked about some risks of over-the-counter pain medication, and you'll see by the end of the discussion today as to why that's an incomplete treatment regimen. Spoiler alert, if you're not looking at the joint movements that I just talked about in the anatomy, you're missing out on opportunities for improvement. So that's the spoiler alert. So this type of condition, tendonitis and tendinosis, generally won't show up on most CT scans, MRIs, or X-rays, because typically what they're looking at is, well, is there arthritis or not? Flat-footedness. So pain increases the more time that you're on your feet. Pain can tend to be on the kind of bottom undersurface and instep. People who are flat-footed probably know it, right? Entire foot is on the floor when you stand, or if your foot is wet and you step on the floor, you'll see the whole foot imprint, right? I'll show a picture of that. And you may get some relief when you put your feet up. And you may get some relief with custom or semi-custom or off-the-shelf foot orthotics to a point. What's considered a quote-unquote normal arch here, where there's relief on the inside of the foot. This is your big toe and that's your small toe. Flat-footed person would have their whole foot on the floor. Generally, if you're getting an examination for that, or if it's a contributing factor, it's oftentimes not regarded because no one's really examining for it. It's shocking to know, and even in orthopedist's office right now, or primary care offices, how little of an examination is done of conditions. But a functional examination where we see somebody stand, walk, and move, we'll start to see some of these tendencies and how it influences them. Heel spur. People who have heel spurs, they know it. They feel like, oh, I have a sharp pain at the base of my heel. First steps in the morning are excruciating. It can loosen up a little bit, but as time goes on, it may be bothersome with high repetitions of walking. They may be advised they've got a heel spur on X-ray, and cushioning in the shoes may help. Pulling the toes back might increase the pain. And a little kind of illustration of that here, with the heel spur, there's excessive bone growth. That may be on X-ray, there may be a line where there's increased bone tissue that grows there. That could be just in response to the type of forces that area's been accustomed to. Plenty of people who don't have foot pain will have that. Some people who do have severe foot pain in the bottom of their foot will also have that. So it may not be the only culprit causing it, and it may be something that's just waiting in the wings, or for some people just a normal finding. Plantar fascial pain is related to that. So on that foot model, if I could see that once more, thank you. On that foot model, if you look at the bottom of the foot foot's like a triangle. Connective tissue comes from this bony bump all the way to the base of all the toes. It fans out. So all the forces through the bottom of the foot come to one area, right? Kind of like all the forces in a lake that's dammed up come to that dam. So the forces that the body exerts on this area gets leveraged on that heel. So it's very easy to see why the bottom of the foot can become irritated from a number of causes. And pain on the bottom of the foot or pain near the heel, we can't assume all of them are just caused by plantar fasciitis. There may be other contributing factors, as you'll see. So plantar fascial pain is basically on the plantar, means on the bottom of the foot. Anywhere from the heel to the foot, you might have some pain. Again, first steps would be painful. The more you use it, the more painful it'll be. They may also be advised they've got heel spur on X-ray. Cushion shoes can help. These people may be helped with custom or off-the-shelf orthotics. Pulling the toes back indeed does increase pain in that issue as well. Neuropathy, we'll talk about neuropathy a little bit. Neuropathy is a little bit different. Pain in the feet may not be related to activity. In other words, it could be bothering you at night, it could be bothering you when you get your feet up. Could be a wide variety of symptoms, but generally, yeah, I get pain in my feet, but it basically doesn't relate to activity level. Doesn't vary much. It can start towards the end of the foot and then start to kind of work its way up where there's abnormal sensation, or it could be hypersensitive, like too much sensitivity in the tissue. When it's present, the symptoms maybe even move up to the knee area. We've worked with a neuropathy patient who I take with a pinwheel and test the sensation, and I can roll it on their foot from their toe, and I've rolled all the way up to someone's knee before. These are like sharp little pokey things that they don't even feel, right? That's how advanced this has gotten. Neuropathy. I'm going to escape out of this. There's a little more I have to say about this. That'll be a little later. Back to our regular scheduled program.
Can I ask a question while you're doing that?
Oh, for sure.
When someone has flat-footedness, is it usually bilateral, or can it affect one foot and not the other?
Usually one will be a little bit more involved, a little bit more so, but typically people have both. Bad feet brought me to the profession, like really bad feet, and so I'm really keen on it, right? So when the foot hits the ground, everything does change. That was the name of a major educational scene that was in the physical therapy space 25 years ago. But yeah, flat-footedness is one of those things where, and if you just look at the feet, you may get some help, but we'd like to have a more expansive view of that. Ankle and foot stiffness. So that's, as it sounds, stiff in the morning and after sitting. Seems to be getting worse over time. Medications don't seem to help much. Seems to loosen up with some basic stretches, but doesn't seem to go away. Always seems to come back. And seems to be getting worse, like I said. It could be in the ankle joint, like I talked about, that hinge joint. Could be underneath in that heel bone to talus joint. Could be in a number of those other smaller area joints. And this definitely does not show up on an X-ray, CT scan, or MRI. You need a physical examination to determine how that area is moving, what should be optimal and ideal for that particular person. I believe what happens is that people get some sort of irritation in their system. Could be from they get overworked, they could have generally more inflammation in their body from the average American diet, which isn't usually good. It can drive inflammation up a bit. They may have wide swings in activity level, but they can have inflammation and irritation. That inflammation and irritation makes tissues more sticky and bring about a slight level of inflammation. That inflammation can then cause a bit more pain, gets more stiffness, gets more swelling, and it starts this process where the connective tissue of those joints actually gets stiff. And that's in the joint capsules. Limited mobility in the big toe. So when you take a step and your heel lifts up, the toes bend back like this. That has to happen. If there's not a significant amount of movement there, ideally we'd like to see from the base of the toe to the big toe, you'd like to see up to about 90 degrees of mobility, at least 70. There's lots of people that we assess that have maybe 20 degrees, just a real little above. And if you don't have the movement there, basic rule of the body, if one area doesn't do something, something else has to make up for it. So if you can't get the bend there, you're going to try to get somewhere else, and that's going to be causing a problem. Individuals with this may have been told they have a bunion. Some individuals may be associated with what's called a forefoot inversion, where the foot tends to have to turn in to get the big foot down on the floor. No one would ever want to see an X-ray, their X-ray of their foot, and have that be seen, right? where the big toe kind of deviates inward. And those can be improved significantly with the right sort of intervention outside of surgery. I say that the X-ray, CT scan, or MRI won't show it. Basically, you have to be looking for it, and you have to correlate to what else they're doing. Nerve-related foot pain. So there's regional nerves. So we talked about neuropathy, and that's a condition in which either from chemotherapy or diabetes, pre-diabetes, or getting radiation, or sometimes we don't know what can cause that neuropathy. Nerve-related foot pain is the ordinary nerves that are in and around the foot can become irritated, they become jacked up. This type of pain, a little bit of activity, causes a lot of pain. It takes a long time to settle down. People may have been diagnosed with things such as plantar fasciitis, they may have been diagnosed with Morton's neuroma, or nerve entrapment problems. Morton's neuroma is that pain that occurs between the toes at the base. Anybody ever had that happen to them before? There's nerves between the toes and that become irritated. That's the type of nerve-related foot pain. There's a lot that can go on, right? And nerve-related foot pain, if you're not looking for it, if you're only looking at problems in the joint, you're not going to find it. Lower back-related foot pain. This can be huge. There's more than a few patients who have foot pain that's not caused by their feet or ankle. It's caused by their back. This pain can be persistent for a long period of time. It can kind of come and go. They may get some relief with treatment, but it doesn't seem to go away. It may worsen without relationship to activity level. Somebody like, well, I'm just sitting around and it hurts a lot, or I wasn't really that active and my foot's really bothersome. They may or may not actually feel pain in their back, or they may not relate it to. Obviously, if someone's not looking at a back for the source of the problem, they're not going to identify that they have a back-related pain. These individuals might have lots of treatment to their ankle or foot. They may have been to multiple providers. They've got a series of orthotics, but they just can't shake the pain. When the view is expanded and we do a proper examination, we find out, hey, you know what? They've got a really jacked up lower back with stiff, painful segments that sometimes even directly cause pain symptoms on the leg. We can do mobilizations and joint work to that area, and oftentimes have an instantaneous change in their symptoms significantly with that.
You got a question? Will
Yes.
sciatica cause that too?
It's essentially a type of sciatica. Yeah, sciatica is inflammation of the sciatic nerve, and that's essentially the nerve that extends to it. There are times when the sciatica will be continuous from the back through the butt, upper leg, lower leg, and into the foot. There are times that the sciatica might be no pain or very little pain here, and all the pain's down there, or maybe even all the pain's in the knee.
See, that's why I said I kind of got pain in my lower back here. I think that's related to my foot pain in my foot.
Well, one thing that...
But it doesn't go down my leg,
Yeah.
you know, and everything I read about sciatica, that goes down the leg.
So there's a subset of sciatica where you don't have to have the continuous pain. It's pain caused from the back, but not continuously through the whole leg.
Yeah.
So we just don't do it. We don't just treat the foot in isolation. I think you probably are starting to get that implication. We don't treat the foot in isolation. Like, we want to make sure people's back, hips, and knees are working properly, because that will determine how your foot and ankle is used. So we will examine that to see what influence that might have.
Yeah.
Is it possible to have more than one issue?
Yes.
Almost always. Almost always. So back when I was a young clinician, with the initial training that I had, the training at that time was real focused on, well, we're gonna treat one thing that causes it. Someone's got some foot pain. Oh, well, if you're kind of biased towards orthotics, you're gonna get them into orthotic. If you're kind of biased towards tendonitis, you're gonna treat the tendonitis. If you're biased towards weakness, you're gonna treat the weakness, and then, well, how come it's not getting better, right? The problem was that would help a certain subset of patients that had that particular problem as their main issue. And it was a real, we call it myopic, or real narrow focus. It wasn't until we started thinking, and then I started thinking, and this is what we do here, we started thinking, okay, what are all the potential things that could be going on with this individual Let's find out from a physical examination what's going on, start to prioritize those things, and just start to knock those off like a task list. So, questions. You guys are really attentive. Sometimes you have lots of questions, and sometimes I don't. I don't mind either. Sometimes I just need a break and drink of water, though. I talk a lot. So.
Do improper shoes or shoe fitting affect treatment schedule?
Most individuals don't have shoes that are ideal for them, and getting proper shoes can help, but it's usually not a major deterrent to getting better. There are some instances, if you got big toe problems and you don't have enough room in those toes, by the time most people find us, they've given up trying to fit their feet into pretty shoes, big and small shoes, right? Most people, even those that wear shoes, like I have a particular type of shoe that looks like a clown shoe, right? It's wider in the front. Shoes hadn't historically been designed like that, right? So if you actually step on and trace an outline of your foot and then cut that cardboard out and try to slip that in the shoe that you're wearing, many people it wouldn't fit very well, right? Yes.
Okay, I got wide feet too.
Mhm.
I noticed your wide shoe when you mentioned it too. Where'd you buy them and who makes them?
So these are Keens, K-E-E-N.
Okay.
They're going to be just about anywhere, Rogans or Shields. But I like them because they're wide.
Okay, I've been buying these Skechers because they're light and they got memory fold and
Yeah, they look comfortable,
forgiving, yeah.
and they're forgiving. They're soft. So
Right.
Got a question here.
Yes.
How about burning sensation in your feet?
well, when I hear burning, I think kind of okay. That's
Nerve?
a nerve-related issue. You know, is there a local nerve issue going on? You can still get irritation from some of those joints. It could be back-related yet. It could be a little bit of neuropathy. So we want to start at how it works, and you'll see this very shortly. In fact, the next portion is a 5-minute miracle. I don't know who wants their situation looked at, but we just kind of take a look at what are the likely things contributing to that. Yeah, that sounds more nerve related, or at least a component of it.
Cause I have that burning, but not all the time. Now, I'm trying to think, today is Wednesday. I think Monday, went to work and everything like that, and when I was coming from work, my feet, right here, right there on the bottom, they started burning. And I thought, what the heck? Oh, what the heck? I don't know. And sometimes I have pain in the back of my heel, back here. But that does go away. I mean, it isn't like and I never lost a night's sleep or anything because of my feet. Never. I can remember. So, everybody says, oh, can you sleep at night or what? I said, I clean up, get my feet washed up, myself and everything with pajamas on. I get on the couch, I put my leg up, and I'm fine.
Nice.
I'm not taking, I haven't ever really taken a lot of medication. When I didn't really know I should be doing it, because I have to go to the hospital and, because I had that blood clot in my leg, I have to have my blood, make sure that it's between 2.4 and 3.0 or something like that, and one day I went, they went, God, it's really high, did you forget your medication or something? I said, no, and then I got to thinking, I said, oh, I took 2 of my daughter's Advil. That will do it, Jane. So,
Sure.
so
Good
I didn't
question.
do that anymore.
My question going back to shoes, okay? I go buy my shoes someplace, and I can't wear shoes from Skechers, and I can't wear shoes from Royce, because my feet hurt so bad. Okay, I buy mine at Leaf, we've been to Leaf on Phelps Street. Okay, very good podiatrists send you there. Problem is they start at $250. Okay, but these shoes start at over 200. I have 3 pairs of shoes I wear, so I don't do it every day, a different pair. And I do have Dr. Scholl's, not Dr. Scholl's, Good Foot Doctor. I bought that old $600 deal 20 years ago, probably 10 years ago. And I still use those that has the high and the low when the arch hurts. But am I prolonging or hurting having a comfortable shoe? I don't understand where you were commenting if it's comfortable, you wear it, but is it not helping you? They're not helping me. Well, they're helping me because I'm comfortable in them. I still get most of the pain, you know. Very comfortable, very soft. Gotta have soft. They're all cushioned. The ones I get at Leaf, they're all cushioned. It's very comfortable to wear, but you can't do yard work in $250 shoes. Okay, you can't. I'm trying to say you can't do this. You gotta have a basic shoe, and it tears you apart trying to do that. So am I hurting not with doing the insoles, the Dr. Scholl's, Good Foot Doctor insoles, and then going back to Patricia shoes or recommended shoes? I didn't quite understand where you're going to on shoes. You mentioned a couple times, couple of shoes.
So the first thing is that I think in a number of patients, shoes may be an issue. For the most part, people have already selected shoes that are comfortable for them that tend to come here.
Okay.
For certain activities, you need a proper shoe.
Yep.
Right? You need proper grip. I'll change shoes based on, look, I need more grip. I'm up on a ladder. I'm on a hill, right?
Yep.
All shoes should have enough width for it.
Mhm.
In the old days, like I had rigid orthotics. Oh, these are 22 bulletproof. They were the most hard-shelled orthotics ever, right? They're the real hard white shell. And I wore them for a while and they were helpful. However, what we tend to find is that you want to use the least amount of rigidity in an orthotic as possible to get the job done.
Mhm.
So, 2 general rules. If it feels great on your feet and there's enough room, do it.
Okay.
Right? Like get in a pair of shoes, walk in the store. If you run, do that. Skip, hop, whatever you do ordinarily. If it feels good, do it. Kind of like the 60s mantra, right?
Okay.
On the other hand, if you can't stand and balance real well on it, and having a pair of orthotics seems to help you balance, like literally in single leg balance, if that's better, you might do better with that orthotic until you develop better balance. So the more imprecise your muscle control is around your hips, the more you're going to need control in the ankle and foot.
So I get that on my better shoes where I don't get it on da-da-da-da shoe. I have to put an insert in.
In terms of you can get a $20 insert,
Right.
Dr. Scholl's. You can go up to a Good Feet store and some people walk out of there with a $1,200 bill,
Yep.
right?
Oh,
We do-
almost $2,000.
We do custom foot orthotics. Ours are $450.
Yeah.
We do a laser guided measure custom foot orthotic for $450.
Mine was $800.
And that's what we do. But those are individualized.
Mhm.
They have the right amount of cushioning and give because you can have rigid or soft. So that's not typically. Most people don't really need that as their primary source. Like if I look across the room and that foot is really flat, caving in, or they really have some issues in the bottom of their foot, that might be a person that needs it.
Okay.
But that's only a small percentage of
Okay.
people where that's the dominant part of their findings.
Okay. Thank you.
So I hope that answered your
Oh
question.
yeah.
Perfect. All right. Well, the next part is the 5-minute miracle. This is the favorite part of the show because presentation because I never know what we're going to find, and it's always fun to see. But what you're going to see is just basically how we do an assessment and what type of interventions we might look at, which gives a springboard to the type of things that we might do in a plan of care. So I'm wondering, if that'd be okay if we take a look at yours?
Yes, I wish you would.
Sounds good. All right. So what we're going to do is we're going to pause that for a little bit. We're going to just move the table a little bit. Tim, if you don't
The other
mind
way?
moving over. For this ankle and foot workshop. So let's start with this. We need to keep it like it won't be fully. It'll be around 5 minutes.
Yeah.
Full disclosure: we spent plenty of time conversing up front, so this is going to be abbreviated. for the purpose of just seeing the process, if you will. We hope to see some 5-minute miracle where she's high-fiving me. We may or may not get to that. That's not important. What's important is you kind of see what's the style and flavor of the type of interventions. Fair enough?
Yeah.
Okay. So, couple
This is my
sentences.
compression
Sentences.
socks.
What's going on with
This
you?
is, yeah, this is my compression socks. Right now, I'm just, sometimes when I walk, I feel like I may have my shoe on. You know what I mean? But I don't. It's kind of something, I don't know, whatever that is all about. But I like to say, I can get ready for bed and do everything and put my pajamas on and go to bed. I never have any pain or anything while I'm sleeping, you know, in the bed, my bed. So, let's see what else.
So tell me what your main complaint is. What's your main thing going on right now?
The burning,
Burning. Show me where.
right here.
In the front of the foot.
Yeah,
Okay. And what really brings that on? When you're on your feet?
yeah, I'm on my feet, but
Not all the time.
not all the time.
And that's been with you how long?
Oh, 3-4 years already.
Getting worse, staying same, or getting
No,
better?
it's about the same, actually, you know.
Okay.
It hasn't really gotten worse, but it's about the same.
Are you okay taking those off?
Yes,
Okay. And you also,
I didn't shave my legs, so don't.
I didn't either, don't worry about it.
Yeah.
You know,
Me
I
either.
said, hey,
So, do I want to talk to it?
If you would, please.
Okay.
We'll just tell everybody it's the middle of
Yeah.
winter. That's okay.
Hey, well, that male
It's
of
middle of
winter,
winter
oh,
in
that would be worse.
Wisconsin.
Okay,
So, point to where you feel that, where the pain is, right around the bottom of the foot. Okay, so in my mind, just for those of you, I'm just starting the process. What do you think? Okay, what can that be? I've got some leading contenders, but we're going to start to work through this.
and I don't know why this has happened, but I think about the last couple of years, I said, why am I getting black and, I didn't drop anything on my foot. Why am I getting black and blue? And now I'm touching it and pretty hard, and it hurts a little, but it isn't like a pain, you know? My pain threshold's pretty good. It
Yeah.
has to be to have these feet.
Clear. enough. So clearly, there's some discoloration there. I'm gonna be taking that into account. There's some added stress to that limb.
But see,
Not
and this
sure
is the one that's got the blood clot in it.
why. You have DVT in there. That
Yeah.
how long ago was that diagnosed?
About
Approximately.
4 years ago, because I was having such pain in the back of my
So,
here. So I went to the doctor and
so you have a blood clot diagnosed, and now for the rest of your life, you're going to be on blood thinners. You have
Right.
to monitor your blood
Right.
levels so that doesn't reoccur. So
Yeah.
for those of you who are
Yeah.
watching or are unfamiliar. So,
Yeah.
Okay.
but
fair
it
enough.
was I could hardly get in and out of the car. That's how bad it was.
Right.
So I thought I better get to the doc and find out what it was. So they took an MRI and they go, you have an old blood clot in your leg.
We love modern medicine for managing things like blood clots. I'm on tape.
Yep. She said, did you have an old blood clot? She said, have you ever had a bad fall? I said, you know, an old farm girl has had a lot of bad falls.
So you're retired now.
Yep.
What type of work did you do?
No, I still work. I couldn't stand retirement.
What type of work do you do now?
I am a morning stalker at Menards. You're in Oshkosh.
Your morning
Stalker.
stalker. Okay, nice. All right.
I like it.
So what I'd like to do, if you would please, I'm gonna have you come to standing, and this time I'm gonna hold the chair still. I'm gonna have you sit on the chair once more. And once you cross your arms, just wanna see how you come to standing without using your arms. Okay, thank you. You can let your hands down.
Okay.
You can stay standing if you would please. Come to
Oh,
standing. Good. So first thing I'm
see,
gonna
now
do
it's
is
hurting me right now.
bothering you right now.
Right there.
I move the chair, please don't sit down.
No, okay.
Okay. So what I'm gonna have you do is I'm gonna have you just take a short walk to the end of that room there. We're just gonna kind of take a notice what your walk is like. And walk here and pass towards me. It doesn't take a trained doctor of physical therapy to identify that she's being very tenuous with that side. She's got a very stiff type walk, and she's got a very short step length.
That's what
Particularly
they told me
she
when I
breaks on the
first
right
came
leg.
here. They go, God, you're really stiff when you walk. I thought,
So
really?
any human can identify that.
Okay,
Okay, so I'm gonna start asking some questions about that.
okay,
What I'd like you to do is come forward a little bit, right here, so you're raised on a farm and you worked on the farm, right? Like,
right,
yeah, you just weren't in the kitchen cooking, you were out
No.
doing stuff. Feet shoulder width apart if you would, just naturally.
do what?
Put your feet shoulder width apart.
What does that mean?
Move your feet apart a couple more inches. There we go, thank you.
Okay,
What I'd like you to do is keep your heels on the floor, but I want you to go down into a squat, to the extent that you can comfortably with control. So lots of bending forward to accomplish that, right? Not as much bending the legs. She bends the legs somewhat, and then she starts to lower her chest to the floor, so there's not as much bend in the ankles.
right, okay,
We ordinarily might assess steps and that sort of thing, but obviously steps are gonna be challenged for you. I suspect you don't go down much with the left foot first.
No.
Okay, so her
but
ankle,
I've worked on this.
her ankle and foot doesn't bend enough.
I mean,
You can see
I'm
that.
at Anytime Fitness for 7 years.
Yep.
And we do wall sits.
Yep.
We do all those things, and I've really progressed in the last 3 years of doing those things.
I'm a huge fan of that. You're way better off for that. 3.5 years she's been exercising. Her ankle and feet are
Oh, no.
not up to par.
Well,
Have a seat.
yeah. I've been a member of Anytime Fitness for 7.5 years.
Okay.
And I go almost every day.
Oh, nice. 7.5 years. Nice. Slide back a little bit. There we go. Come forward just a bit. All right. Pull your big toes back. Hold them back. Don't let me move you. Don't let me move you. I'm going to assess the strength of her legs here. Hold your foot up here. Don't let me move it. Don't let me move it. I believe she's a farm girl. Hold. Little noise in the joint there. Wouldn't be a shock if she had a little bit of arthritis in her knees.
But I just put that on my mind.
I'm going to specifically check the move. Actually, I'll have you lie down for
Okay.
that portion of it. I'll give you that. Yeah, you did. I want to measure ankle mobility. This is a right angle, like a book angle. Okay. Now, mathematicians would say that's 90 degrees. We'll call it 0. What I'm going to be looking at is I want you to pull your toes up as far as you can. This is her comfortable side, quote unquote good side, and I'm going to measure that. That measures right now, I'm going to call about 12 degrees. 12 degrees. Pull back here. She's working like the Dickens, but she's only getting, she's not even getting to a right angle. She's 2 degrees from a right angle. In other words, this
I
is the
got
ankle.
problems.
When her heel touches the ground, her foot gets to the ground. This is right now a 90-degree angle. Ideally, for an active person, you'd have up to 15 degrees beyond a right angle. She's at least 17 degrees off. So she's got profound stiffness in that ankle every step she takes. Muscles are solid and strong. I'm going to bend her knee up and remeasure that. Why am I going to do that? I'm going to do that because I want to see what her calf muscle flexibility is like and see if it's the calf muscle or if it's the ankle joint. The range of motion is a little bit better, but not where we need to be. At 9 degrees, so she's still off a bit. Her calf muscle is tight. I suspect, given her history of DVT, deep vein thrombosis, blood clot, that the tissues and connective tissue here had tightened up, and she never got it lengthened afterwards. It was painful and swollen. That inflammation stiffened tissues up, and she never got either both the ankle joint worked out and that muscle. So her calf muscle, the gastrocnemius muscle, this muscle here, doesn't lengthen as much as it should, nor does that ankle bend as much as it should. Her big toe, is that seen clear? Big toe, straighten this out. Big toe, yeah, I'm happy with that. Allow me to move you, you relax. That's close to 90 degrees, I'm happy about that. I'm gonna assess her hip joint quick. She's been working out, doing stuff at Planet Fitness. She's pretty flexible there, maybe not perfect, but pretty darn good. So,
Oh, gave me a pain in my.
cramp there? Yeah. You can bend this one up.
That is crazy.
Isn't that nuts? All right. So what I'm going to do is I'm actually going to do some joint mobilization techniques to help loosen up that ankle and foot joint. I'm going to do that. The intention is to create more mobility in this part of the ankle and foot joint. I'm going to do some techniques to get more length, to work that connective tissue. So I'm just gonna straddle the table here.
Okay,
It's the easiest way to do this. I get my flexibility program. Let that foot behave.
okay,
All right. So what I'm doing is I'm just simply stabilizing her just below that joint. I'm gonna do some gentle stretching to this area. I don't know if you can see that real well.
Can you guys see that?
Tell you what, let's say you spin around.
oh, yeah, okay. This, me over here, yeah,
That's
okay.
good. Then you can bend this knee up to keep your back comfortable. And I'll be bend this up. There we go. That's better. So, stabilizing here.
Oh my God. I'm not kidding you, it's just unbelievable. There we go, there we go.
That should behave a little bit.
Yeah,
All right. So, to you folks, it'll look like I'm not doing much at all. What do you feel as I do here, as I do this?
yeah.
What do you feel?
You got your hand around my ankle and
Uh-huh.
you're pulling up on it.
Uh-huh.
Doesn't hurt, but I can feel that it's stretching out.
This is a technique we call joint mobilization. So the joint tissue has a joint capsule. That joint capsule is what holds in the joint fluid for any given joint. All the joints in the body have joint fluid in them, and they have a bag that holds that fluid in. That's connective tissue. That connective tissue, in presence of inflammation, irritation, or inactivity, will stiffen up. And when that stiffens up, what happens is it doesn't allow normal motion to occur at that joint. So I'm literally doing this sort of thing. I'm exaggerating on this model, but that's what we're doing. Internal joint massage. Ultimately, at the end of the day, her ankle and foot needs to move more for her to, she's already doing the steps in a day. She's a stalker, she's going to work out. She may even
When I
go,
worked at Quick Trip, and I worked there 12 years, I walked 14,000 steps a day.
at Quick Trip. Now, the other thing is I'm gonna assess that ankle, that heel bone. Notice here, there's a little bit of movement here.
Mm-hmm.
Is there any movement here? Nothing.
Nothing.
So what I'm assessing there is this action of this, which no one ever thinks about, right?
Mm-mm.
I was never trained in this in physical therapy training, right? But that is vital movement to occur because that's part of the natural walking cycle. We'll work on this a little bit too, as long as we're here. This might take this out to a 13-minute miracle, but we'll continue to do the work.
Are you stretching that muscle in the thigh, in the calf?
Nope.
Okay, just working just on the ankle.
Yep,
Okay.
I'm doing this.
Okay.
Right. This is better than
Yeah.
this is better than the pec deck at Planet Fitness.
Yeah.
Or you go to Anytime.
Any
Fitness.
type fitness, yeah.
Little classier joint.
Oh, yeah. We've got
Oops, I said that on
trainers
tape, didn't
and
I?
we used to have one, his name was Tommy. And I was having trouble with my leg. So he says, well,
Pull your,
we went and got my thing that you could, put on your foot, and then I'd raise my foot up, and I'd pull back. I did that, for a good 3 months. Plus they have things at Anytime Fitness that you sit down and you bring your legs up. Boy, that I've been doing that for quite some time.
I'm a huge fan of strength training, Dave, you know. Pull your toes up, way up, way up, way up. Now, I don't know if you can see whether or not that's got more motion there. It's got more motion there. She's registering 8 degrees of motion now. She's up 10 right now in the short term. So right as of now, she's got about 3/4 of the movement that she needs in that ankle and foot. That ankle joint is still stiff. That heel bone is still stiff. She's gonna get up. We'll watch her walk. She'll report what she's feeling. And we'll talk further. Bend your knee up. But I'm really happy with the outcome. Bend this knee up. Take your time. Come up to sitting on the table. Swing your feet around. Shift back a little bit. when you're ready, come on down to standing.
Okay.
So we're doing this in stages. I want you just to sense, to feel. What does it feel like standing on that now?
Yes. All right.
Different than before?
Yeah.
Take a walk across the room, please. What do you
Feel
feel?
very good.
What do you notice?
I think I'm lifting my feet more.
They're both moving now, almost the same, where before.
Yep, the toes are
It
bending.
was, yep, it was just like, kinda like shuffling.
You know what, I never ever, cause when I was here and I talked to, Robin, she goes, you're not walking, does that hurt when you walk? And it never did hurt, it didn't say it was not, it wasn't hurting. But
Have a
that,
seat.
that I couldn't believe,
That's hard to believe.
isn't it?
Every day, all the time, right? It's very simple. The joints have to move. If the joint can't move, the muscles can't function properly. If the muscles can't function properly, they get weak. If the muscles are weak, you can't do the things for extended periods of time that you want to be able to do. She may have other things going on, right? Like we're gonna have to, like, the question is, well, how long will it last? What do I need to do, right? So her body wants to pull back into some of those old patterns. If she does nothing else but this today, and doesn't change anything else she does, this is not gonna be long lasting. Now, if she takes my advice and stretches her calf muscle, not like a mad woman, but just comfortably, 30 seconds, 2-3 times a day, for 2 weeks, she'll probably maintain that, but she's gonna need more work. That calf muscle needs some work. There's that swelling that's throughout there that's not normal. We've gotta kind of get some of that circulation going with other
Cause my leg is swelled,
The
right?
left, the right one's more swollen than the
Yep.
left
Yeah,
leg, but
but
that's
this
also
is
your,
the-
the one you had the operation.
That's
on.
what-
Absolutely.
Okay.
We can, but tissues change over time.
Mhm.
That can change, right?
Mhm.
And we can work that. So here's the thing, is that there's phases of progression, right? And first phase is to relieve. We've got a little diagram for this, so I'll go off the wall and show you, right? First thing is we gotta relieve pain and inflammation. Right? We got a bigger diagram of this, but first stage as we get to recovery is to relieve pain and inflammation. We want to get to this stage. Next stage, we want to correct the imbalances that cause that. Joint stiffness, muscle imbalance, there might be some nerve-related issues there, maybe a host of things going on. Then we want to strengthen the muscle in its newfound range, right? That's the next phase. Get it moving. We can do some nicey-nice stuff. The nicey-nice stuff gets it moving. Towards, as we get further into planet care, we're not just doing nicey-nice stuff. You're starting to work a little bit so that the tissue can manage some of the loads that occur in daily life. Then we want to make sure that she can preserve her abilities so that she can do a wide range of things. She still wants to stock shelves, she still wants to get doing her workouts, and she can be doing those better. And maybe there's other things that she wants to do that she hasn't told us yet. Maybe she wants to go to kite festivals and go to fairs and
I wanna play pickleball.
play pickleball. That is not a solid leg to play pickleball with. Someone's gonna hit it towards her right side, she's gonna be like, nope, not going after that one, right? To her left side, all day.
That's
Right?
why, really, that's what I
Yeah.
do. I wanna play
Right.
pickleball.
Perfect, right? So awesome, she wants to do that, right? So but whatever that is for her, so at the end of the plan of care, she's left with a program. She knows exactly what few stretches to do, exactly what strengthening she can do for her. That's not gonna be a problem because she's already involved in the strength training routine. She's been exercising already. I'm a huge exercise fan. This is a classic case. Exercise ain't enough. Doing the hands-on work ain't enough. You combine the two, now you're talking, right? She may also benefit from some dry needling to calm things down in terms of
That's what
nerve-related
Robin
issues.
said, we might have to do that. She said, you're not scared of needles, are you? I said, why would I be scared of something that's gonna help me?
Well,
You know, that's the way I look at it.
so that's why I love coming to work every day because we can really help out with outcomes, like get people to achieve more than they could from any other kind of program, if you will. Hands-on work is good, exercise is good, combine them, you get much better result. Then you start teaching people what to do to self-manage. Maybe we talk about some footwear. We didn't get into the discussion. This is why I don't think it's important to start with a discussion of which orthotic do we recommend or should I have an orthotic, because if that ankle and foot doesn't move properly, it doesn't matter what kind of orthotic she has, it's not gonna help. right? Now, she might have an orthotic that's more or less comfortable, but now when her ankle and foot is better, and we fully assess what muscle control and balance, we haven't even got into that yet, then okay, she's got better balance and muscle strength around her hip. When she steps on that foot for that few microseconds or seconds, then she's got a much better muscle control, and then maybe she doesn't need such a stiff orthotic, or maybe she doesn't need one at all. I don't use orthotics. I used orthotics when I was 11 years old.
Say,
Right.
whatever.
My feet were horrible. I literally had the orthopedist who evaluated me that wanted to fuse my feet, was a good friend of my family's. He took pictures of my ankle and feet when I was a young boy and wanted to fuse them. My mother completed high school, my stepfather never did. They had enough horse sense that that didn't sound right to them, right?
Mhm.
I went a different route. I saw him about 12 years after that. He said, he actually did an operation on my stepdad. He said, did you have a kid that had problems with your feet? Yeah, this is Eric right here. He said, take off your feet. I'm like, all right. He did an examination. He says, this isn't the same one. I said, I'm the same dude. Like, we've been in church every Sunday. Same church the last 15 years, right? Like, he just couldn't fathom that someone can change outside of a surgical intervention. Just wasn't in his realm of possibility, right? So, but when you change some of these things, you change the way that it functions over time. And regardless of the age. Obviously, she comes to me at age 25, she's gonna change at a faster pace than she is at age 65, right? But the change is still possible.
And it all stemmed about, I felt like I don't want to fall. You know what I mean?
Right.
And that's the
I mean,
reason
talk
I'm
about
here.
grit. Like, I did not expect to see her, when she told me that she works out on a regular basis, to struggle so much with basic walking, right? So, but anyway, your movement capability will change dramatically.
Mhm.
Awesome. Couldn't ask for a better demo. I'm glad you got some relief. Where do we go from here? So you all have looked through your paperwork there. Obviously, you see the Google reviews of folks that we've helped here. You've had a chance to see this. Next step is, hey, look, you've been here. Why not come in for a complimentary discovery visit? We'll go through a very similar process to this, maybe a little more in depth. You might fill a little more paperwork. Those are just complimentary for you attending here. We can do any, most people want to see what their insurance will contribute to our plan of care, so we can do the insurance verification ahead of time.
Light as a cover.
And either way, oftentimes people have deductibles or co-pays. We'll let you know exactly what it looks like in terms of the number of sessions and what your commitment is to a plan of care, or how many sessions it will likely take for you to get to the result that you're looking for. And that's it.